Good afternoon, everyone. Thank you so much for joining us today. My name is Terry Wilt, and I'm the Director of Community Engagement for Mayo Clinic Health System in Southwest Wisconsin. On behalf of our entire organization, I welcome you to today's community forum titled Dr. Greg Poland 2.0, a no-nonsense COVID-19 discussion. This is our sixth community forum devoted to COVID-19 topics and our second featuring Dr. Poland. He's back by popular demand after drawing a large audience and receiving high praise following the September 10th event, in which he addressed many of the misperceptions and misconceptions surrounding COVID-19 vaccines. With today's community forum, we continue our quest to bring you current and reliable information to help you make informed decisions. Dr. Poland is one of the world's foremost infectious disease experts. He is director of Mayo Clinic's Vaccine Research Center and a leading voice on scientific evidence supporting the benefits of COVID-19 vaccines. Dr. Poland is also editor-in-chief of Vaccine, a peer-reviewed medical journal. He's chaired or served on every federal committee involved in vaccine decision-making, including the National Vaccine Advisory Committee and the Advisory Committee on Immunization Practice. He's regularly featured in national news stories by NBC News, USA Today, Business Insider, and others. He's in high demand as an advisor and a speaker, and we're truly fortunate to have him with us again today to share his knowledge and answer your questions. We invite those of you attending via Zoom to submit questions anytime during the presentation using the Q&A function. We'll get to as many as possible later in the program. And now, to begin today's discussion, we turn to Dr. Paul Mueller, Regional Vice President for Mayo Clinic Health System in Southwest Wisconsin. Dr. Mueller is a professor of medicine and a professor of biomedical ethics in the Mayo Clinic College of Medicine and Science. He's been recognized as a top internist by U.S. News and World Report and has authored or co-authored more than 130 peer-reviewed publications and hundreds of book chapters, abstracts, and columns. Dr. Mueller, I turn it over to you.
Thanks, Terry, and welcome everybody to this important forum. We, of course, want to get to Dr. Poland's presentation, so I'll be brief and share a few slides with you on an update of the current state of the pandemic. So community transmission in the United States by county remains high. You can see this heat map of the United States and its territories, and by and large, they're orange. And that means that community spread is significant throughout our nation. On the right-hand side, you can see the daily cases, and the recent surge is illustrated on the far-hand side of that picture. Now, we're encouraged that there seems to be a drop in cases, but we must remain vigilant, and you'll hear more about that from Dr. Poland. The slide below that, or the picture below that, is deaths, and you can see those are the daily deaths, and we see that correspondingly with the surge with a small decline, but again, vigilance is necessary. Next slide. To date, in the United States, there have been more than 43 million cases of COVID-19 disease, nearly 700,000 deaths, but 76% of people aged 12 plus have had at least one vaccination. But focusing on the number of deaths, that's more than the number of Americans who died in World War II, and the deaths continue. The highly contagious Delta variant accounts for 99% of cases, whereas in May that was less than 1%. Unvaccinated persons account for most COVID-19 hospitalizations and deaths, and hospital systems are busy with COVID and non-COVID patients. We're full. This recent surge followed a period of calm and is concurrent with school openings, festivals, and things like that, making the current surge dangerous. The good news is that treatments for COVID-19 infection that prevent serious disease and hospitalizations are present. For example, monoclonal antibody therapy, and that's a highly effective agent in terms of preventing serious disease, hospitalization, and death. And we do a lot of that here at Mayo Clinic, including here in La Crosse. And then there's the preliminary trial results of oral molnupiravir, This is an oral medicine that also appears promising in preventing serious illness and hospitalizations and death. Look forward to that emerging as a treatment option in the months to come. Finally, there are the public health measures that are critically important: social distancing, masking, hand hygiene, and most important, vaccines, which will be the focus of this presentation. Next slide. So in the last presentation, I described Dr. Poland as not only a close personal friend, but really an incredibly good physician, great teacher, highly respected researcher. And what you may not know, he's been ranked as one of the most influential people in the global vaccines world, 25th on this list. I'm sure he's higher on other lists as well. So I'm going to turn it over to Dr. Poland on this topic. I think you're muted, Greg.
Does that show up now?
Yeah.
Okay. Thank you, Paul. That's a very generous introduction. Well, I called this the ongoing pandemic, falling into the same trap again. And I'm just going to go through some high-level data and then get right to questions. I thought this was interesting. This is, hold on just one second. I'm going to try to, there we go. This is from a letter written by Martin Luther in 1527. I shall avoid places and persons where my presence is not needed, that's social distancing, because I might cause their death as a result of my negligence. Interesting morality there. If everyone would help ward off contagion as best he can, then the death toll would indeed be moderate. But if some are so foolish as to not take precautions, now we would say masking, distancing, vaccines, and aggravate the contagion, then many will die. And note that this was written 300 years before we had an understanding of the germ theory of disease. Well, George Bernard Shaw was, I think, right. He said, we learn from history that men never learn anything from history. Well, these are some Wisconsin data. This was last updated in mid-August. It would be even more dramatically different if we had the data to put in here. But this is looking at cases, hospitalizations, and deaths. So on the left-hand side are fully vaccinated. So for every 100,000 fully vaccinated people, there would still be 125 breakthrough cases, vast majority of those very mild, almost 5 hospitalizations, and 0.1 deaths. That's fully vaccinated. What about people who are not fully vaccinated? Well, for the same 100,000 people, there would be 369 cases, not mild, 18 hospitalizations, and a little over 1 person would die. This is Idaho. I thought the way they displayed this was helpful. When you look at their medical system across the state, 98.9% of cases are occurring in people not fully vaccinated. 98.6% of people hospitalized were not fully vaccinated, and 98.7% of people who died were not fully vaccinated. So, you know, if you're not, or somebody you know is not fully vaccinated, you've got to do a lot of mental gymnastics, let's say, to try to explain away these data. Now, this is a study that just came out this morning from the University of Iowa. And what they're looking at here from the 3 months ending September 15th is they're looking at people who simply are categorized as living in urban or rural areas. The rural is in the red dashed line and the urban in the blue line. And what you see as we started into the Delta variant surge is you see a dramatic difference just between urban and rural. And that difference is accounted for by vaccination. So for folks living in a rural area, you have to ask the question, what do they know that everybody living in urban areas don't know who are not experiencing high case rates? Similarly, with mortality, an even greater difference at the population level, dramatic difference in the curves, depending on where you live. And again, it's where you live is a marker for other things like masking and vaccine acceptance. So as of this Monday, there were 706,000 deaths in the US. That means 1 out of every 464 Americans have died as a result of COVID. That's the equivalent of 22 airplanes, each of which carried 400 people, falling out of the sky and everybody aboard dying every week for 80 weeks straight. I'm pretty sure I couldn't get you on that next airplane. And yet that metaphorically is exactly what people who are unvaccinated are doing. US males overall have lost 2 years of life expectancy. If you're African American, 3 years of life expectancy. This is more than since World War II. And I note, we called that a world war. More deaths than due to the 1918 influenza pandemic over 100 years ago. Again, recalling that George Bernard Shaw quote. And almost 2,000 Americans die of COVID every day. And as Paul noted, about 65% of eligible Americans are fully vaccinated. Now, I'm not wanting to set up a competition here with Wisconsin, but I do want to note that 91.5% of Minnesotans over the age of 65 are immunized fully. The other issue I often hear people say is, well, you know, I heard of somebody who got COVID and they didn't die. And that may very well be true. In fact, odds are that depending on their underlying medical conditions, they won't die. But the odds are also that they'll develop long haul symptoms. And please don't discount these. These are people who oftentimes can no longer work or who have breathing problems, who cannot think in the same way that they did before. And you see the vast number of symptoms that have occurred in organ systems. This, by the way, Mayo Clinic contributed to this article. One of the very unfortunate things about how this pandemic has been handled in the rejection of vaccines is that it has disproportionately now moved toward being a disease affecting children, whereas in the beginning of the pandemic, we did not see this. We've had a 240% increase since July of the number of children and adolescents hospitalized with COVID. Last week, there were almost 250,000 new cases in kids and teens, and about 2,000 children are hospitalized each day in the United States, which is an almost 30% increase from the previous week. Since the start of the pandemic, over 5 million known cases have occurred in children. 20,000 of them have been hospitalized, and very unfortunately, over 500 dead. Now, these are not children that could have gotten a vaccine since it's not yet available, but clearly they're around adults who could have gotten the vaccine. Fortunately, even with 20,000 hospitalizations, the risk of hospitalization is low in a child, the risk of dying even lower. But about 1 in 4 of the new COVID cases are now occurring in children. So I've asked this perhaps before of this audience, which risk do you want? You only get 3 choices. There's no avoiding one of these 3 choices. You either get vaccine or you lock yourself in a room like Howard Hughes, or you will get infected. You will get infected in time. I try not to be dogmatic, but this is one of those areas where one can safely be dogmatic. If you are not vaccinated, you will get infected at some point. So if you're a wise person, you're going to have to balance known risks and known benefits, not what some rap star or athlete says, but what people who collect and analyze and scrutinize data are publishing. One of these areas is in pregnancy. As of this past week, 125,000 known cases in pregnant women, 22,000 hospitalizations, and 160 deaths. If you're pregnant and you get symptomatic COVID and you've not been immunized, you have a 70% increased risk of death. I note only 31% of pregnant people have been vaccinated. So if you're pregnant or planning on pregnancy, please consider getting vaccinated. One of the big issues in our society is hesitancy and rejection. And I want to point to the bottom part of the graph, the lightest blue. These are people who say they're not going to get the vaccine. Even in the face of 1 out of every 464 Americans dying, that number has not changed. So there are a group of people where data, where facts are not going to change their mind. But I do want to note the other groups, the cautious and the interested, are increasingly getting immunized as they see the reality of COVID-19. As you know, a third dose has been recommended in people who are moderately to severely immunocompromised. And this past week, last Friday actually, the EUA for Pfizer only, and only in those 18 years and older, we now have recommendations for booster doses. And they are of two types. A should recommendation for people 65 and older, or who live in long-term care facilities, or who are 50 to 64 with underlying medical conditions. And then two may receive a booster dose. 18 to 49-year-olds with underlying medical conditions. And then this last one, which was a bit controversial, the ACIP panel voted against including this one, and the CDC director overruled that and added it. And I happen to think she's right here. But 18 to 64-year-olds who are at increased risk of COVID exposure and transmission because of occupational setting, that's most of us in the healthcare field, or institutional setting based on individual risks and benefits. Now, do booster doses work? On the left side, you see 18 to 55-year-olds. On the right side, 65 to 85. And you see in both cases, 1 month after dose 2, you see a drop. I'm not showing you the month before dose 2, but you see a drop that jumps up after dose 3. So people get a profound boost in antibody response after getting dose 3 or a boost. Now, one other thing that I think is interesting, that across the US and Europe, the highest COVID-19 vaccination rates are seen among those with the highest levels of education, those who have scientific training, physicians and pharmacists, those with higher levels of wealth, those living in urban versus rural areas. One that breaks my heart, we see higher levels in non-Christians, and those who live in the north versus the south. Why? What should any of those have to do with the medical decision of getting vaccination, other than maybe the first 2 or 3, something like that? So if you don't if you're unvaccinated and you don't fit into these categories, again, you have to ask yourself, what do people with the highest levels of education and physicians with scientific training and people who have higher levels of what do they know that I don't know? And maybe I should reconsider. And then final thought, and that is what I call viral probing. Last year, I think I was the first to say to the media, I'm worried about a twindemic. This year, I've been telling them I'm worried about a tridemic. Why is that? Well, we'll continue to have COVID-19. Very likely, the trend of dropping cases right now will continue for a few more weeks. And then as the colder weather sets in, it will resurge because everybody will have pretended that it really, really is over, and they'll be wrong. The next is RSV. We've already seen surges in this across the South. And then influenza. Though I'm cognizant of the fact that I'm talking to people in Wisconsin. Let me point out that just thus far in 2021, that's why I call it viral probing, there have been 10 novel flu strains that have infected people in the US, a novel H1N2, which we have not seen before, a novel H1N1 that has been detected 3 times so far in Wisconsin, and a novel H3N2, which has been seen in Iowa and Wisconsin. So we're keeping our eyes on this. It would be a mistake to think, well, we didn't see any flu last year, and why are we going to see any this year? It's because we did the experiment. People wore masks, and guess what? We had essentially no influenza. There's your answer to the question, do masks work? Now that we've taken masks off, we've already had more flu cases so far in this flu season than all of flu season last year. And with that, I will stop and take questions.
Thanks, Dr. Poland, for that wonderful summary. So I'm going to start out with some refresher questions, and then we'll get to those submitted by the audience. I think you've answered the question, why get vaccinated? The data are clear. You've also answered the question that vaccines are very effective. So the next question, if you could just review with us again, are vaccines safe, and how does it compare to actually having the disease?
Yeah. So, I'm going to answer, as I always do, the question with blunt truthfulness. And this doesn't always make people happy, whether they're scientists or non-scientists. Wisdom relies on balancing risks and benefits. So what are the benefits of getting the vaccine? Well, they are considerable. We're basically only seeing people die of COVID who are unvaccinated or who were vaccinated, but whose immune systems are compromised enough by age, medical condition, or treatment that they didn't respond well to the vaccines. What are the risks of the vaccines? And there are risks. There are risks to everything that men make. Anything made by man has risks and benefits. Nothing man makes is 100% safe or 100% effective. So those risks vary based on your gender and your age and medical condition. Let's take one of the highest risks, and this may be difficult in balancing risk and benefit for some parents. Young adolescent males have a risk of developing an inflammation of the heart called myocarditis, as high as 15, 20 in that per million. Okay, so their risk of dying is quite low. So what about that risk of myocarditis? Generally asymptomatic. If it is symptomatic, usually resolves without treatment in a day or two. Are there any long-term side effects to that? None that we've discerned thus far, but Pfizer has committed to studies that go through 2025 to examine that. And oh, by the way, many of our other vaccines can also cause myocarditis. So you're always balancing risk and benefit. Let's take me. I'm 66 years old, otherwise healthy. My risk of getting hospitalized is about tenfold higher than a healthy 20-year-old. My risk of dying, about fourfold higher. The risk of the vaccine in me, well, it was a couple of hours of low-grade fever and a sore arm. Which one would you pick?
Thank you. We've already gotten questions on this, and I had it as a refresher. Let's just say I had COVID-19 infection 6 months ago or recently. Should I get the vaccine?
This is a really good question. And it's one where we would like to have more data. One of the difficulties in answering some of these questions is what you and I know from studies published 6 months ago doesn't hold up as the airplane continues to fly, as the pandemic moves on. We didn't have Delta 6 months ago. Now we have Delta. The answers all change. So in this particular case, we know that if you had COVID infection, let's say a year ago with a non-Delta variant, there's a nice study done, observational study in Kentucky, showing that if you had previous infection and did not get immunized, your risk of getting reinfected is about not quite 2.5-fold higher than people who got it and were immunized. So we clearly see elevated breakthrough cases, reinfection is a better word for it, in people previously infected. That is not a surprise to us. Everyone listening to me has been infected with coronaviruses multiple times. We call those seasonal coronaviruses, and you probably call them the common cold. Lots of things cause the common cold, but one of the viruses that most often causes it is coronaviruses. And yet immunity doesn't last, so we get infected over and over and over again. If you're an average person living in America, you get 2.2 respiratory infections per year. And probably one, if not both of those, might be coronavirus. So immunity is not persistent. So whether you were infected or whether you get vaccine, your immunity will wane, just like with influenza. We give an influenza vaccine every year because the strains change and immunity wanes. So even with prior infection. Now, I will say, if you survived it and had no complications, prior infection plus vaccine immunity is superior immunity. It's really good immunity.
Yeah. Well, you had mentioned children and approvals. What's on the horizon for kids younger than age 12 in terms of vaccines?
Yeah, so the rumblings, and my ear is pretty close to the ground. The rumbling is perhaps by Halloween, there will be an EUA for children 5 to 11 years old.
What's an EUA?
Pardon me?
What's an EUA?
Oh, it's an emergency use authorization. And that will only be for the Pfizer vaccine. And then shortly after that, each of the other vaccines will come forward to FDA. It's just that Pfizer started their studies first and had their vaccine first. Now, the dose for those children is going to be a third of the adult dose, 10 micrograms rather than 30. They're also finishing their study in children 6 months to 4 years old. That'll be a 10th of the dose, 3 micrograms instead of 30. What do we know thus far? Saw the same reactogenicity that we did in adolescence, which is pretty low overall. Did not see any safety side effects. And young kids that are healthy like that, just superior immunity. I mean, it blows us old guys out of the water.
Yeah. So with the variants, do you see the way vaccines are manufactured and prepared changing as we respond to what we know about the biology and science of the variants?
That's a great question, Paul. And in fact, Pfizer and Moderna have both been working on what are called variant-focused boosters. Whether those will prove to be necessary is another question, because what we've seen with this is we had the Wuhan ancestral strain, then we had Alpha strain, then very shortly after that, Delta strain, really starting in the July, August timeframe. Already, we started to see introduction of Mu and Lambda and a couple of variants that don't even have Greek letter names yet. It's unclear to me whether a variant focused is a good idea, because by about the time you manufacture and distribute it, you'll see cases waning and a new variant take over. So what they've started to shift to is pan-corona vaccines. And that's where I think we're going to see the most value. But in the meantime, we do clearly see that even giving a booster of the original vaccine offers considerable protection against the Delta variant.
Thank you. And I'm going to ask one more question, and then we'll see what Terry has in the queue. So you talked about the twindemic or the tridemic. We get the flu shot every year. Can I get the flu shot at the same time as the COVID booster?
Yeah, the answer to that is very clear. Yes, you can. Ideally, if you're just going to get two vaccines, one in each arm, so if there's any undue local reactions, we can kind of sort them and not say, gee, you had a sensitivity to one vaccine and have it wrong as to which one. Let's say you have to get 3 or 4 vaccines. A lot of people are behind on their vaccines. For you adults, we want to be sure you're up to date with your acellular pertussis, your shingles, your pneumococcal, your flu, and COVID. That's 5 vaccines. You can get more than one vaccine in the same arm. We just like to separate it by an inch or more.
Good to know. Terry, what kind of questions do you have?
We have all sorts of questions coming in on a variety of topics. A lot of them center on the vaccine and children. So I thought we'd start with this question, which is representative of many. Many parents are very concerned about the vaccine's potential long-term effects on children. Some may opt not to vaccinate younger children when eligible because kids generally don't get as sick as adults. How would you advise these parents?
I understand that. And I will tell you, as a vaccinologist for 4 decades, I share that, wait, pause, and let me see the data and really think this through. It's easy in the older adolescents and adults. That's an easy data-driven decision to me. When we get to the younger kids, the issues are, and I'll try to go through it pretty quickly. The issue is, are they going to get sick, hospitalized, or die? The issue of long-term symptoms, and then the issue that goes beyond the child, which is transmission to other people and the continued propagation of the pandemic. So what I would say as a parent with the younger children is, I don't want them to be sick. I want them to be in school and getting educated. I want them involved in all the socialization activities that are important in that age. So that's a soft weight toward vaccination. What would pull me away from that? Basically, I have no concern over efficacy or whether they're going to work in kids. They clearly do. So then the only concern becomes, what about side effects? Well, I would probably, and I'm being just bluntly honest with you, if I had a normal, healthy kid, I would look at the data for myocarditis. That's really the only major side effect that's being seen. I'm taking off the table, they had a fever for a few hours or for a day. They didn't feel well for a day. Those are transient and they resolve on their own. Those studies will shortly be coming out where we get a better definition of, is the risk of myocarditis higher the lower in age we go, or is it just in that band of adolescent younger males. So you notice I'm not saying a definitive yes or a definitive no, because I think in fairness, we want to see those data and weigh them.
Okay, thank you. And a related question regarding children. If an unvaccinated child has already had COVID-19, is it worth the risk to have them vaccinated?
That's a great question. Some of these questions, I think, A, somebody's thinking really well and I should recruit them to my research group. And B, boy, I wish I had the answer to that bolstered by data, and we don't. In other words, we don't have studies yet that in the younger kids that we're talking about, where we can compare and say, here's a kid that had natural infection, as it's called. Here's what their antibody level looks like over time in the face of these variants. And then another set of kids that were infected, got vaccine, and we follow them. Don't have enough of those data yet to be able to say anything definitive. In general, what we have consistently seen across the older age groups is that prior infection plus vaccine, you get many-fold higher immunity from that.
Okay. And then staying on the topic of children or teens and vaccines, can you share any research or data that's been collected on young females 12 to 16 having menstrual cycle changes after vaccination? How can a vaccine cause these changes?
Sure. So it's not clear yet. Let me start a little bit further back. Temporality is not causality. In other words, just because something happened near to the time you got a vaccine doesn't mean the vaccine caused it. It's a hypothesis, and that hypothesis just got funded by the NIH. They just let out some awards to study that very question. What do we know so far? Well, anything that can cause a low-grade fever, stress, anything like that can cause minor perturbations to a physiologic cycle, whether it be a menstrual cycle or any other chronobiology type of physiology. What we know so far is that those perturbations have been mild and they've been transient. That has induced concern in women of extrapolating even further. Does that mean that there could be some effect of this vaccine on my fertility? For example, I'm planning a family. Should I be getting a vaccine or not getting a vaccine? And we can be much more definitive here. And in fact, CDC has published data and other organizations have published data showing no interference with fertility, no increased rate of fetal loss, no increased rate of congenital birth defects. And at least one study done, as long as we're on the topic, in males who got the vaccine, they actually had an increase in sperm count and semen quality. I think it was a statistical aberration. I don't think, please don't rush out and get another dose of vaccine because you think that'll help it. But the point being is they saw no decrement in sperm count or semen quality.
Okay.
Terry, I'll give them a few here as you sift through some data, more of the questions that I saw, because I think it goes back to the boosters and the prior infection. How soon can I get the vaccine after prior infection? And if I had the Moderna or J&J, do I qualify for a booster, or when will that happen?
Yeah, I've gotten a lot of those questions. So let me try to take them one at a time. I personally, unless a new mutant were to arise that we are not facing right now. So every answer I'm giving you, please, if people watch this sometime in the future, you'd have to recheck what I'm saying because new variants could change the answer and advice we're giving. But right now, if you had documented infection, not I think I had, but documented infection, then I personally would not get a booster any sooner than in that 90 to 120 days. The reason for that is the data show you really have good protection up to that 90 to 120 days, and then we start seeing reinfections occurring. We can measure it. It happens often enough. So in that 190 to 120 day, that's the ideal time period after which I would get a booster dose. The second part of that question, Paul, was...
Let's say I got Moderna or J&J. Do I get a booster, or when is that going to happen?
I know particularly, and I feel it, for the people that got a J&J vaccine, they're very, very concerned and worried of when is it my turn to get a booster? I think the Moderna booster will be coming recommendations will be coming very shortly. There is a lot of work being done. Remember that the Pfizer dose and boosters are the same, 30 microgram. The Moderna primary series, if you got that, was 100 micrograms, and they're looking at a booster that would be half that, 50 micrograms. So I think we'll see that shortly. J&J, the last entrant so far into the US market, it has done their, what they call it, Ensemble 2 study, and shown that with a second dose, they dramatically boosted immunity. So I don't see that they're going to have any choice but to do that. Those data have gone to FDA. They, as we talked about before, the group of people saying, what's taking so long? And another group of people saying they're rushing it. So the FDA has to scrutinize those data, and my prediction for the future is we'll see a booster dose recommendation for all 3 current vaccines.
And regarding boosters, we have a number of folks asking if there's any benefit to be derived where if you had the Pfizer as your initial vaccine, should you get a booster of a different vaccine to gain benefits?
Good question. For me as a vaccinologist, that answer's easier with the same vaccine platform. In other words, which mRNA I predict isn't going to matter. Which adenovirus you get doesn't matter. The question is, what about mRNA and adenovirus? So there's been a small study done in the UK, showed that it worked very well, but increased reactogenicity. So what about, I got a dose of Pfizer, now I want to get a dose of Moderna. I think that's going to turn out to work just fine. Legally, the issue is we don't have data that have gone to FDA, and therefore it does not fit under the EUA provisions. So as an institution, for example, unless there were some compelling medical or scientific reason, we would not do that at this point.
So I have a question on ethics for Dr. Mueller. One of our attendees at the last forum noted that you had commented very thoughtfully on the ethics of mask mandates. So their question is, people seem to be increasingly callous toward unvaccinated people who become sick and sometimes die from COVID-19. Some go so far as to say medical care should be denied to those who refuse the vaccine. What are the medical ethics around caring for those who contract COVID-19 after refusing to get the vaccine?
Well, it's simple. It predicates around love and compassion. That's what we do as healthcare providers. We're informed by our values. We will take care of you and love you and get you through that illness. It isn't any different than someone I'm caring for who has a heart attack and is a long-term smoker, or lung cancer and long-term smoker. I wish they hadn't done that, but that's no time for me to cast judgment on that individual. We take care of them, we get through their illness, we care for them, and we try to do it the best we can. So there's no role really for, I would say, rationing care for patients who have not received the vaccine and now unfortunately have COVID-19 disease. We will continue to be guided by our values, and we'll continue to have forums like this one to convince people of the merits of public health measures like masking, distancing, and vaccines. And one of the questions related to early treatment. That's why we stood up in less than 48 hours an infusion center for monoclonal antibody therapy when we got it. And that clearly prevents hospitalizations and death when we get it to patients early enough. And that's why the oral medication is so exciting to see that trial result. The fact is, and Dr. Poland is the expert on this, even if we manufactured 100 million doses of that oral medicine, the distribution and the efficacy of treatment for acute disease is not going to come close to what public health measures and vaccines can do in terms of preventing hospitalization and death.
Yeah, and I would just heartily endorse what Dr. Mueller just said. You know, the Hippocratic Oath that I took said nothing about excluding people from medical care, even when they have, you know, caused, if you will, their own illness or through neglect of something. That's not our job. Our job is to care for everyone and anyone. Paul and I served in the same division, and he'll remember that back after 9/11, there were a number of us, myself included, that volunteered to get smallpox vaccines so that if we saw any smallpox, now there's a vaccine where you have to sit and think about the risks and benefits. If we saw any smallpox cases, they needed a cadre of doctors and nurses and respiratory therapists willing to walk into that room and take care of patients. And we did. We got those vaccines.
Thank you both. Because we said this was going to be a no-nonsense discussion today, I want to make sure that we touch on some of the more contentious topics that our viewers are submitting. So we have a number of questions about the use of ivermectin and hydrochloroquine and studies that show that these are effective, or examples of other countries where they're used widely. And people are asking why we don't use those here. What's behind that? Can you comment?
Sure. Did you want me to take that, Paul, or were you?
Sure.
Okay.
I have some information on that myself, but you're much more expert than on this than I am.
Well, you know, the general topic of that is what's called repurposing. The idea that you could screen already approved drugs in the laboratory and use that as a way of down selecting the tens of thousands of drugs we have down into a few that could, that's feasible for us to study. A whole bunch of those: azithromycin, vitamin D, hydrogen peroxide, hydroxychloroquine, ivermectin, and a million more, it seems like, are proposed. Often the first studies that are done are hypothesis proposing studies that non-critical readers miss. Those are studies that have critical study flaws. And so the way that you have to do it is you then subject these to randomized controlled trials. So where those have occurred, they have not shown benefit. So these are randomized, double-blind, placebo-controlled trials, and they have not shown benefit. Now, where somebody might push back on me is ivermectin. So with the ivermectin studies that have been done, I would encourage you to see the meta-analyses where they take out the one study that had a fatal study design flaw in it, and it shows no benefit. Let me remind you, for those that are taking, going to, we're not supposed to use brand names, the stores that sell farm supplies and things like that, and you go and buy this. That is not regulated for humans. You're taking a risk beyond anything I would ever ask you to take with an FDA-approved drug. The manufacturer has said it doesn't work, and oh, by the way, it can induce birth defects. Is that really the answer, as opposed to a vaccine? Having said all that, NIH has committed to studying a number of these, and there is an ongoing high quality study that will look at, among other things, ivermectin.
So I would add on the ivermectin, there was one question, can you send the link? I'm not sure if I can, but all you need to do is search Cochrane Library ivermectin, and you'll get the analysis that Dr. Poland is talking about.
Yeah.
And the authors concluded that the evidence is not there to support widespread use. They always say more trials are necessary, but
and in this case, that trial is being done.
Yeah.
Another area of interest to our viewers today is around acquired immunity or natural immunity. One of our questions is saying that there doesn't seem to be much information being shared about this. The other says lately there's been speculation that a challenge to the federal mandatory vaccine mandate based on natural immunity is coming. How does that compare, and is it actually a reasonable option?
Yeah, this is, I don't want to be dogmatic in this area, because this is an area where, as more data are gathered over accumulating time, we learn more and more. Would I say that you're protected if you recovered, you have a normal immune system, you had documented COVID, and you recovered a month ago or 2 months ago? Yep, you're good. What about at 120 days? Nope, you're not good. We clearly see an increase and increasing number of reinfections in a situation like that. And I just explained earlier why that is. Now, I'm going to be I'm for those that are in infectious disease or immunology, I apologize. I'm simplifying here for the word picture of it. When you get infected with the virus, your body, your immune system is distracted into making antibodies against all of the components of that virus. So it doesn't make a very deep response, but it makes a broad response. Antibody to a lot of those components is irrelevant. It doesn't protect you in any way. With a vaccine, you're getting a very narrow immunity, but extremely deep immunity. And that's why efficacy in these trials has been, from the get-go, in the 95% plus. I mean, it's stunning. You have to remember that when these trials started, FDA was hoping, as were we as vaccinologists, for a vaccine that was at least 50% effective. And FDA said they would license something in the context of a pandemic that was at least 30% effective. These are in the high 90s. And it's just amazing.
Another question about a somewhat potentially controversial topic. A nurse in the Department of Health and Human Services recently claimed that physicians are underreporting adverse reactions to COVID-19 vaccines because the reporting process takes too long. She claims that adverse reactions are far more common than what's being reported. Can you comment?
Sure. It does depend on what adverse reaction you're talking about. Most people are probably not going to report an hour, a few hours, even a day of low-grade fever and headache. They're just not. Those are data we get from controlled clinical trials. So the real issue is about the things that are more rare than that take hundreds of thousands to millions of people. And we don't have clinical trials and never will that size. So again, like many questions, there's elements of truth in that question and elements of misinformation. One of the misinformation in there is it's too hard to report them. Any of you, if I, talking today, told you about the side effect that I had to my mRNA vaccine, 4 hours of fever and chills, you are perfectly within your right now, and I'm not suggesting you do it, but you can go on to the internet and type in VAERS, VAERS, and inside of 2 minutes, you can report that my side effect, my adverse event. I've already reported it, so you don't need to. But it's that easy to do. Now, where some difficulty can come in is for serious events. Let's say somebody claims death or an organ rejection or something like that. Then what happens is CDC scrutinizes those data. And many times what you find is that somebody developed, I'll just make things up, somebody developed diabetes on Monday, they got their vaccine on Wednesday, somebody reported it as related on Friday. Well, when you go into the records, you see, wait, that time sequence doesn't work for claiming that it was caused by the vaccine. So you have to be careful about those, but this is a passive reporting system. Anybody can report any adverse event for anybody.
So it seems
I might just add, oh, sorry, Paul, go ahead.
Well, it seems there are several questions, in fact, about reporting and documenting cases. So both you and I said there have been roughly 700,000 deaths in the United States. That's right from the CDC.
Yeah.
And it's also followed by some of the other trackers, for example, Johns Hopkins University and Mayo Clinic. So these are, in my view, pretty reliable sources. So do you debate those figures?
Yeah, I think where it, death is, as we often say, is a pretty hard outcome. We're probably very close on that one. What's hard is when somebody's found dead, for example, you don't always know what the cause of that death is. But that's not 100,000 people. If that's 1,500 people, okay, it was 700 and 500 people instead of 700,000 people or something like that. It's with things like mild and moderate infection. I think we miss a lot of those. I think most modelers would say that the numbers reported of how many people have been infected are lower than reality. How do they construct those models? You go, for example, to blood donors, and you begin to realize, wait, 1 out of every 8 here has antibody. And now moving to, wait, 6 out of every 8 have antibodies here. So you can figure some of those things out. For safety, you have to remember that VAERS alone is a passive reporting system. We have a system of 4 or more overlapping integrated systems. So we can look, for example, at Mayo Clinic. What side effects have we seen? Kaiser Permanente reviews their data every week electronically, looking for any red flags. The Centers for Medicare and Medicaid Services does this every week. So there's all these, this is why in the US we have the most robust vaccine safety system in the world, because of these overlapping systems and because we have an electronic medical record and claims databases where you can investigate these things very quickly.
Yeah, and I think the data are very robust. I think the public can be reassured regarding that. But then there's the practical matter of care providers like you, myself, nurses who care for patients with COVID disease every day in our hospitals and in our intensive care units. And it's a tragedy to be with a patient and their family, and that patient dies despite our heroic efforts. And they were unvaccinated. Again, we love them, we care for them, we don't cast judgment, but we're seeing this in our hospitals and across the nation every day. The practical reality is that people are dying of this disease.
I talked 2 weeks ago, Paul, to one of our colleagues, I won't mention his name, in critical care. He just needed somebody to ask a question and vent. He broke down crying. They had admitted I think he was 40 years old, otherwise healthy, but he got COVID, was pretty moderate, got admitted to the hospital, started requiring oxygen, started needing more. They needed to move him to the ICU, and as it turned out, intubate him. I believe he did survive, but he had been against masking and against vaccines. And on the way to the ICU, he said to the nurses, I want you to do everything science knows to do to save my life. And there was an irony in that moment of everything science knew to do was to prevent this with masking and vaccines. Now we're in a position of we likely are going to be able to save your life. We don't know what the quality of that life will be, but it's going to take extraordinary measures to save you at this point. And they did, but it was unnecessary.
I think that's a great place to end our discussion today. We are right at 1 o'clock, and we do want to be mindful of people's time. So I want to thank Dr. Poland and Dr. Mueller for sharing their time and expertise with us today. We hope the information has been helpful to you. We'll be providing a link to a recording of this presentation to our Zoom registrants via email. If you're watching us via live stream or other means, please email us at the address on your screen, and we'll be glad to share the link with you as well. You can also reply to that email with any feedback you'd like to share on the